It mainly deals with various intraoperative complications during phacoemulsification. So first talk is on confronting wound-related issues by Dr. Meenu Mathan. Over to you, sir.
Okay, good afternoon, ladies and gentlemen. Thank you, Dr. Sandhya, for this opportunity. And I'll be talking on wound-related issues in phacoemulsification. No financial interest in this. And in a phacoemulsification clear corneal incision, this looks as simple as this. You know, I just usually support the globe and then make a single plane entry. That's it. So nothing can go wrong actually, basically, if you do it well. But then, first it will start with the keratome itself. If the globe is turning so far down like this, it's a blunt keratome. It can cause DM stripping, it can cause irregular entries, it can suddenly get into the anterior chamber. So all these, when I started, people started coming. So they were waiting for me to start to come. That's why. So, when I find this kind of a keratome, to begin with itself, if it doesn't move in smooth, I just drop that keratome and then get another one. Don't try to struggle with keratomes. And can you just, where is the mouse? Yeah. So these are marked keratomes. And you see the second hand here, stabilizing the globe. Usually I do it like this, either with the McPherson to close the incision and stabilize, or nowadays with the 23 gauge MVR which I use, which goes into the anterior chamber. And it plugs the paracentesis. It holds the eye in position, and then I can create a clean wound. So I'm telling all these to prevent all the problems which you can have. It's better to prevent an incision problem, because till the end it will have a problem. So this is the 2-plane incision which I like in some cases, but mostly 1-plane incision will also do. And a single plane incision, generally once I am inside, I just cut the inner lip 0.25 millimeters, as you can see. It increases the space for maneuverability of your phacoprobe. So it makes you feel a little better. And the outer is exactly 2.4, so it doesn't leak. And at the end, hydration. I am very insistent on hydrating well and closing the wounds and seeing to it that it is closed on the table on pressure. Because the patient is going to blink just after the case, and if you just leave it open, it can always leak, and then it can suck back fluid from the fornixes, and then it can cause unnecessary ingress of bacteria or whatever. So I just confirm it as dry it and make sure it doesn't leak spontaneously, and also pressure from a different location to see that it's not leaking. So this is how I close my incisions on table every case. So this is one case where I found a diamond blade. I was excited to use the diamond blade, and I just used it. It looked okay, but then it was looking a little larger. I thought I'll go ahead with this, but see, it is so large an incision that iris just keeps coming into the incision. So the pupil will go down, you will have iris chafing, you will have burning of the iris, all those things, and it will be a messy surgery. So do not make sure what your company person is suggesting for their sleeve, and use that keratome. So 2.2 nowadays I use a 2.4, because see here it's almost 4 millimeter. So a 2.8 sleeve is too loose in that, and it will be too messy. So either put a suture and do, or just abandon this and go to a different location and create a 2.2. This will just like that close. So don't use abnormal looking keratomes which you are not used to. This is the one in which, see, happily we'll be phacoing, but at the end of the day, when you take it out, you will see something like this. If you had been causing, I'll come to that. This is a phaco burn. It's a small burn. Still, it can cause difficulty in closing the wound. It can cause astigmatism. So if it is not closing, definitely put sutures till you find that it has closed completely. This is another one. There are two reasons for making an anterior entry. One is a blunt keratome. So if you keep on going, it will not go in, and finally you will enter. This is almost 3 millimeters into the clear cornea. So every maneuver after that will cause distortion of the incision, and you won't be able to see things properly, and access the whatever you want to access will be difficult. Second thing is learners hesitant to press down. So if you keep on going, suggesting that you will now enter, okay, go a little more. So you'll keep on going, and finally you'll end up going too far anterior. So at the point where you want to enter, dip down, press, go in, and then straighten out the tip, and then complete the entry. So this is how I suggest to close. We can put radial suture also because it's a small incision, but if you have a burn and other things, it's always better to do a horizontal suturing. Go along the floor of the incision, come out, and then on top of the superior part of the upper lip, and then in between the upper and lower lip, bring it out, and then make knots. Horizontal will always close, approximate the incision better than radial sutures, but radial is easier to make, see, and do also. But here, see, this is a paracentesis. Still, it has been manipulated so much that a tight Simcoe was put in through that, and tilted, turned, and all those. So even if that does not close, suture that. And you can notice that I am suturing once, and at the end of that suture, if it still doesn't stop leaking, I will put another suture. There is no harm putting in a suture. We don't promise patient that there will be nothing, no suture, nothing, no. At the end of the day, if the vision is good, you can always tell on the skin part there is a small suture. We can just take it off on the slit lamp itself. You can do on a later date. So this is another dreaded problem which can happen. This is an SICS wound, but still, when you manipulate some incisions in phaco also, you can get this kind of a DM stripping. So this DM stripping is a bad thing to have. Even last week, one of our trainees had it, and it was sometimes, mostly it is from the incision site. When you have people with very hazy looking cornea, some arcus, large arcus, old people, and crocodile shagreen and all those, their DMs are loose. There are people with the loose DM. Believe it or not, there are people with loose DM. So you hydrate it a little bit, suddenly you'll see a flap coming off, or even with just entry of anything, there will be a small flap hanging. So be very careful when you're entering inside and manipulating this. And sometimes you get it along paracentesis or incisions through which you have injected viscoelastic. So viscoelastic or something goes in between, then it is very difficult to oppose it. You will have to have venting incisions and then place in C3F8 or something and iron it out for a long time, and then because we had to bubble a case twice because there was visco in between the DM and the stroma. So coming last to the femto incisions, sometimes it is difficult to identify, but if you dry it and wait for some time, you will identify the epithelial cut area and identify that, and the depth has to be identified. And this instrument is crucial to have, not just the cyclodylus spatula or a Sinski. This has the different plane in which you can go down a bit and then identify the plane and go in. Sometimes it doesn't fully open, so don't struggle or push through. Sometimes you can detach a DM if you try to push it through uncut areas. So if it is definitely uncut, use your keratome to extend it to the adequate size. And sometimes, mostly when you do right eyes, you will see superior arcus like this, where femto cuts do not work. So in such a case, always use your blade to open it up. And here again you can notice that this cut is too anterior into the clear cornea, the paracentesis. So this is so easy to open if cut well. So it just like that opens, but this one I would just abandon it and make a peripheral paracentesis and go ahead. Otherwise it will be difficult to manipulate through these instruments. So these are some tips which I would like to offer for having less complications with the wound in phacoemulsification. Thank you very much. So I'm sorry that I have to go for another session immediately. So I can't take questions at the end. If you have questions right now, in 1 minute we can answer.
Thank you, sir, for that excellent talk. Sir, I want to ask one question, sir. If there is a DM tear at the clear corneal wound, before start of phaco, what strategy would you do, sir?
Such DM tears happen as small flaps. Small flaps. So small flaps, definitely you can watch and go in. I do not irrigate while going inside. That is one thing which I don't do. I irrigate and get the air out, but then I go in dry and make sure that I don't drag this along. Depress the posterior lip and go inside. And with each movement, don't retract the phaco probe too much, so that the irrigation comes very close to the incision site. And also don't retract the sleeve also too much. Don't expose it too much so that when you retract it. So don't disturb that area much if it is just a small flap. And especially in a good looking cornea, a healthy looking cornea. But if it is already a large flap, 2-3 millimeters, I would suggest better not to manipulate it, because we cannot keep on looking at it. We say you have one eye on this, one eye on that, nothing like that. You will be looking only at the phaco tip only. This you cannot keep on looking. Otherwise, you have to change your thing and look at this and stop phaco. It's not possible. So if large one and vague looking ones, better abandon and make an incision next to it.
Your the point that some eyes are more prone for DM stripping, I totally agree with that. But then often we might overlook all that. And one question is, did you take that video just to show how the wound cornea gets distorted, where you made a slightly anterior entry? Why don't you do your rexus through the side port?
This was done by a trainee.
Training.
So actually, side port is also a definite option when you have this kind of a problem. Go through a side port. But after that, again, you have to go in with your hydrosection. You have to use the main probe. So anything you use, you'll have to tilt. Go through the cornea and tilt down. You'll get striae and the globe will turn away and all this. So this was actually done by a trainee. Later on, it was converted into an SICA, so that's why we didn't bother much. But we had to tell them that this is not the way to do, because they were straining to enter, waiting, keeping on going forward, finally enter, you enter 3 millimeters anterior. So that's what happens. Okay, thank you.
Thank you so much, sir. Our next talk is on recognition and management of rexis extension by none other than Dr. Ramamurthy. Sir needs no introduction. He is the chairman of Eye Foundation Group of Hospitals, and he is an renowned phaco and refractive surgeon, and with vast experience. Over to you, sir.
Thank you so much, Dr. Sandhya, and thanks KSOS for this wonderful opportunity. This is a topic given to me. Let me try to illustrate the points I want to make with the help of some practical videos. This is an old video of mine, and one of the factors that you need to understand is that the reason rexis extension occurs is because whenever intralenticular pressure exceeds the intracameral pressure and the anterior capsule bulges forward. This is an intumescent cataract. I'm observing all the usual steps. I made a small neck, went inside, used cohesive viscoelastic, basically removing cortical elements. Whenever it's flocculent, you may have to do it in more than one occasion. And then initially started off with the capsular rexis needle, then using the utrata forceps because it gives. But watch here right now, there is escape of viscoelastic, the chamber is shallowing, but I got tired of doing this rexis, and that's when it gives way. Ideally, what I should have done is to stop right there, refill with viscoelastic, and then gone ahead. Manage the case and manage to put in the intraocular lens, but obviously a compromise solution. So the point I want to drive home to the youngsters is you might have to, in these kind of cases, even 3-4 times you might have to refill. And once the you get a rexis in this particular situation, the case is almost 80% over. One of the other reasons for a rexis extension happening is a fibrotic element like this, and you can see me trying to do this. If I use a utrata forceps and just try to pull this along, this is going to rip through to the periphery. So that is something you should not do. And essentially, I'm using a micro rexis forceps. There's a certain amount of distortion of the wound because of the direction, and I create a nick over there so that you can still see that the capsular rexis at the edge of it, you can see that fibrotic patch. If only I tried to drag this over, then it would have ended up with a rexis tear and anterior rexis tear, which could obviously have a propensity to extend across the equator. Look at this situation, little more serious than what we saw in the earlier case. It's a extensive fibrotic patch over here. Fortunately, here again, it's close to the side main incision, which is temporarily placed. Essentially, I've done a laser LRCS in this case. That's why you see the capsular rexis margin over here. But exactly in this region, we have a fibrotic patch. If you try to stretch this too much, or even use a utrata forceps and try to drag this out, then invariably there will be extension to the periphery. In these situations, sometimes depending on the situation, You might even have to make another incision, use microrhexis forceps, go along to that area, and then cut the area of the fibrosis, and then subsequently proceed with the rest of the scenario. And as you can see over here, that fibrotic patch is still there, but centrally it's a clear capsular bag that we have, which is ready to receive the intraocular lens. Even when you're using a LRCS, please concentrate in this area. You should not automatically assume that this is a very simple walk in the park case, but you can see over here that there is an area of discontinuity over here, and I did identify that, and you will see the way it's not a simple down up technique that I practice, but essentially I would make sure that I swing the rexis in such a direction that I create the rexis in this area. Basically, this is a discontinuous area, and if I had just pulled on the rexis, then it could have just ripped apart. Once the nucleus is removed, you can see this area where you can see that small bulge over there, which has been artificially created with the Utrata forceps because the laser did not do it. And you see a small nick like this. This can happen either because of the phaco tip or because of while polishing. And in these situations, if you go ahead and introduce the intraocular lens, again this can extend posteriorly. So what we do, you can use a Utrata forceps or a microrhexis forceps. I use a aspiration cannula itself to go ahead and round it off. Is extremely important you do that. Otherwise, if you just try to introduce an intraocular lens with that small nick over there, invariably it will extend to the equator and maybe beyond. Look at this interesting situation. I have most of the rexis is almost done, but right here, whenever it is pointing towards the equator, that's a dangerous situation. You know you can be in trouble, and basically this is a more recent case of mine. And essentially what I did is to go through through the side port with the microrhexis forceps. I round it off. I thought that the case will get over quite comfortably, but still, even though we have a rounded rexis here, there is an area of weakness. And when I did a limited hydrodissection, immediately I could see that this extended. And you can see this going all the way to the equator. Fortunately, not extended beyond. When you have to deal with the phacoemulsification, a situation like this, use low IOP, moderate parameters, and go ahead and with the whatever technique of your choice. In these situations, even a stop and chop is good. But you can see the more tentative way I am doing it, in the sense that the chopping also, to the extent possible, it's not along the line of the rexis runoff. And once I've made my initial chop, I bring the nucleus fragments out into the anterior chamber and do a horizontal chop so that there's no stress on the capsular bag. And now it's a dispersive viscoelastic that's going in to protect the cornea. Then some amount of normal HPMC, because the dispersive viscoelastic itself is thermogenic. And all the nucleus evacuation is done in the anterior chamber outside the capsular bag, though as posteriorly as possible, so that the deleterious effect on the endothelium is also not there. And obviously you would refill but the amount of phaco power used was quite minimal, and the phaco probe assay stays in the center without moving. You can see the large rexis runoff that I have had, but obviously it's doable to go ahead and do a phacoemulsification. Another situation where I have a rexis runoff, most often it occurs when you think the rexis is over and you are slightly relaxed, and often some of the viscoelastics has leaked out, and you can see here again I have a rexis runoff. And as you can see here, it's a very soft cataract, not amenable to chopping. So essentially what I do is to go ahead and create a central crater. Again, the parameters I use are significantly less than what I would normally use, but then hardly any phaco power is needed. And subsequently, I rotate the nucleus by 90 degrees, and the separation I do with 2 Sinskey hooks, and not creating any stress on the capsular bag in these areas. And then subsequently removing the nucleus. Again, it is in the anterior chamber phacoemulsification that we essentially do, after which the intraocular lens is introduced. This is another situation. I essentially want you to look at this brand little maneuver, and I go ahead and inflate with the viscoelastic, start with the rexis, and everything seems to be going according to plan. But there is one stage over here when there seems to be a tendency for the rexis to run off to the periphery. So essentially, just keep watching this. As you can see, I am doing it more carefully, more consciously, than what normally we would do. But this is the point. I am evacuating a little bit of cortical matter from the bag so as to lessen the intralenticular pressure. But can I take a minute more? As we see here, this is tending to direct in this direction. This is a dangerous situation. The brand little maneuver is nothing but the tendency would be to push in this direction. But instead of doing this, you lay back the capsular rhexis along the direction in which came and pull it in this direction and pull it inwards. And that's exactly what I do here. I explained it because it may not be very obvious in the video. Now I go in with a micro rhexis forceps and essentially hold it, and then this is a regular Utrata forceps. I hold it, and as you can see, I pull it back in the direction in which it came, and then also internally, and thus I gain control over the rhexis, and then the rest of the surgery is fairly routine. And you can exchange in these situations the Utrata forceps or the micro rhexis forceps, the capsular rhexis needle, depending on your comfort. And time spent on doing this, always time well spent. As you can see over here, there is a certain amount of tendency for the rhexis to run off, which you are trying to control. And just because you have a $500,000 machine, that does not essentially assure you of complete rhexis in every case. In intuition cataract like this, because of the surge of the cortical matter which sometimes occurs, you can see I have a disrupted capsule in spite of the fact that I used a LRCS platform. Then I had a couple of flaps on either side, and the patient had already received a multifocal intraocular lens in the other eye. So we go ahead and implant the lens of the choice in this patient. Obviously not a compromised outcome, but then it could be dealt with only this. I would skip this video, and thank you so much for your kind attention.
Thank you so much, sir. I have one just doubt. In the third case you showed, there was a thick fibrotic plaque under the capsule. So could the femto complete a cut through that plaque?
No, I mean, I had used a femto in that case. That's why you could see the border of the rhexis in the rest of the place. But the thick fibrotic patch, it doesn't do anything to it. So that's why I had to. But it gives you a nice template for the rhexis, and so you get an almost rounded rhexis. But that area you have to cut with the scissors only. Thank you. I also have another talk in the same session, so please excuse me.
Now we have the Chief Instructor, Dr. Sandhya, talking to us about zonular weakness and IOL decentration, how to optimize outcomes. Dr. Sandhya is a senior cataract surgeon and UVA specialist at Giridhara Institute, Cochin. Over to you, Dr. Sandhya.
So zonular weakness and IOL decentration, how to optimize outcome. So this patient had pseudoexfoliation. Pupil was not dilating well. The nuclear sclerosis was around 3, and you can see a space between the iris and the anterior capsule, which indicates zonual weakness. So the pupil was stretched using Coughlin hooks, and a cohesive OVD was injected just inside the pupil to cause viscomydriasis. And as you can see here, during capsulorhexis, the entire bag lens complex was moving, and this indicates zonual weakness. And you should aim for a larger rhexis in these cases, because then the chance of capsule phimosis will be less. Now, after completing rhexis, you should do a very good hydrodissection. And then once the hydrodissection was done, when the nucleus was tapped, you can see the capsule coming forward here. So this indicates severe zonual weakness there. So a groove for SICS tunnel was kept to remove the nucleus fast in case it drops. And then here I am using, since it's a generalized zonual weakness, I am using 4 capsule hooks. If there is regional zonual weakness, you can use capsule hooks only in that area. So these capsule hooks gives anteroposterior support to the capsule. And then they've got long hooks. So that will reach till the equator of the capsule, whereas the iris hooks reach only just beyond the rhexis margin. And then they have got, these capsule hooks have got atraumatic tips. And after supporting the capsule well, so the nucleus was rotated bimanually so that it causes minimum stress on the zonules. So after that, when you are sculpting the nucleus, you should use enough phaco power so that there is no push on the sonules. You don't have to push the nucleus, and again the sonules, there is less stress. So after chopping this into nucleus into multiple pieces, during the emulsification of the last piece, I could see a line there on the posterior capsule. So this can be either a posterior capsule rent or capsule fold. So I injected OVD. So when the OVD was injected, this line disappeared. So this was a capsule fold and not a posterior capsule rent. And then the Sinskey hook was placed just under the phaco probe so that the bag doesn't get aspirated, because the bag is very floppy and you can see the entire bag is moving during phaco. And there were multiple folds on the capsule, and this indicates sonule weakness, especially of the posterior sonules. So once this emulsification was over, so OVD was injected before withdrawing the phaco probe so that there is no sudden shallowing of the anterior chamber. And then in these cases of sonulopathy, the cortex will be very sticky because there is no countertraction by the sonules. So these cortex were stripped tangentially and carefully. And then after cortex removal, again the bag was filled with OVD. You have to fill the bag completely. So this I'm about to insert CTR. So before inserting CTR, you have to fill the bag completely. And then the eyelet of the CTR was taken beyond the area of maximum sonule weakness so that the closed area of CTR supports this area. And then a monofocal single piece lens was placed inside the bag. So this capsule hooks were then removed carefully without damaging the rhexis margin. You have to just retract the sleeve and then take these hooks out. And then at the end, triamcinolone was injected. I could see few vitreous strands here. So those were removed with the vitreous cutter. And then pilocarpine was injected and the lens was looking stable and the pupil was round. So but a sutured CTR would have been a better option, but that was not available at that time. But you have to keep watching this patient because they are at high risk of bag CTR complex dropping into the vitreous. But at the end of 1 year, this patient is stable. Now this patient had a nucleus cirrhosis of grade around 4 and the pupil was not dilating well. So as you can see here, there is some folds at the apex of this rhexis which indicates sonule weakness. And after rhexis, a good hydrodissection was done, and here the nucleus was rotated, just pushing it down and then rotated so that the stress on the sonules is minimum. And here I am using an IOL trap technique, that is after filling the anterior chamber with OVD, to give equatorial support to the capsule, the CTR was placed inside the capsule, and the 3-piece lens, foldable lens, was injected into the anterior chamber. So the leading haptic was carefully taken under the iris and was just placed over the rhexis margin. So if you directly inject this onto the rhexis margin, sometimes the haptic will go under the bag. So it's always better to inject into the anterior chamber and then carefully dilate onto the rhexis margin. Then the IOL optic was trapped under the rhexis. So once this is done, the round rhexis becomes oval. So once the IOL is trapped, it's a stable position and it prevents fibrosis. And so you have got IOL in the bag and the haptics in the sulcus, and those haptics gives extra anchorage to the lens. So the chance of subluxation is minimal. And at the end, a fourthropupilloplasty was done. In this patient, everything was going fine till the completion of emulsification, almost up to the completion of emulsification. So then I could see the rhexis margin coming forward here. So this was an ominous sign. So I put OVD. Then when I retracted the iris with Kuglen hooks, I could see the large area of sonular dialysis here, about 4 to 6 clock hours. The sonules in this area was looking normal. So injected OVD and the CTR was inserted in such a manner that it doesn't increase the area of sonular dialysis. So this is the CTR of normal size, and then the eyelet was dialed into the bag using a Sinskey hook, and then that was released with an iris repositor. And then a single piece foldable lens was placed inside the bag. And in this case, as you can see here, the round rhexis becomes oval once the 3-piece lens was implanted in the bag. This is because there is lack of countertraction by the healthy zonules 90 degrees away from the area of contact of the haptics. Now in this case, everything was going okay till the implantation of a 3-piece lens. And during removal of the OVD, the IOL started to decenter and the air bubble disappeared. So the causes of decentration at this level are one haptic in the sulcus, placing one haptic in the sulcus and the other in the bag, breaking or kinking of the haptics, or there can be some peripheral zonular dialysis or PCR. So here the optic was well inside the bag because you could trace the optic margin all around, rexis margin all around the optic of the lens, and there was no damage to the haptics. And then OVD was placed and then the CTO was injected. But again during OVD removal, lens started to descend. So I just dialed the lens out of the bag and then placed the haptics in the sulcus and then did an optic capture. So the lens was remaining stable, but during the removal of OVD, I could see some suspicious lines here. So I thought it may be a PC errand. But when I went behind the lens and tried to remove the OVD, see that area looked better and there was no extension or anything. And I injected pilocarpine and then people got constricted and the lens was stable. Actually in this case, I don't know what is the exact reason for the IOL subluxation. So to summarize, you should identify the signs of zonual weakness and you should aim for a larger rexis. You should have a good hydrodissection and you should rotate the nucleus gently. You should always use support devices like capsule hooks or CTR when needed. And tangential stripping of cortex is preferred. And you should stabilize the IOL with either CTR or sutured CTR or by IOL trap technique. Thank you.
Thank you.
Third one, madam. Because third one where I showed that oval rexis. No, there was no CTR. I just put the lens, that's all. And then the area of contact of haptics got stretched, but there was no stretching 90-degree wave because the zonules were weak there. So that's why it assumed a spindle shape. I didn't put CTR, sir. Had I put a CTR, it would have become round because it would have equalized the force.
Actually, CTR, in another case, when you have put it from a main, I think that when the AC shallows, then the area of dialysis will increase. So it's always best to insert the CTR to the side. So the main port is not touched at all.
Okay, thank you, Dr. Sandhya, for the beautiful videos that you've shown. Next speaker is Dr. Soni George, Circle Head of Dr. Agarwal Eye Hospital in Kerala. He's talking about dealing with nucleus drop, tips and tricks. Over to you.
Thank you, Jacob. At the outset, let me thank Dr. Sandhya for enough cataract surgeries, that's all. At some point in time, you will have at least a fragment drop once you cross a significant number. And obviously, at any stage in life, it is going to be a nightmare for you. And what could be the causes? It's always a better idea to avoid such situations as much as possible. So it could be a peripheral extension of an anterior capsular tear, or an incomplete rexis, or going in for a wraparound PC tear. It could be from a second instrument, so always be careful with the second instrument not to cause damage to the capsule, anterior or posterior. Aggressive phacoemulsification. The settings, you overestimate the grade of the nucleus, and then you go ahead and you end up in damaging the posterior capsule, and then subsequently nucleus drop. Aggressive phaco settings and predisposing factors. So earlier it was only the posterior polar cataracts, but with the number of intravitreal injections, which is even done by most of the anterior segment surgeons also these days, the chance of a lens touch and a subsequent inadvertent pre-existent PC rent is a possibility. So aggressive phaco is could be one of the reasons. And see, the surgeon is going very aggressive. Actually, it's going to the periphery and using a lot of energy. And you can see he ends up with a large posterior capsular tear with a significant amount of nucleus still remaining. The first thing you should do is not to pull out the instrument. Very, very important. If you see something like this happening, to reduce the amount of damage, to tamponade the vitreous from coming up, you should never come out, push in viscoelastic like viscoat, plug the posterior capsular rent as much as possible, and then go ahead with cataract surgery. And bevel down phaco, nowadays most of us don't do that. Okay, again underestimation, overestimation of the hardness of the cataract, and then you end up in a rent. So what are the warning signs? So first of all, we should try and, instead of dealing with the dropped nucleus, you should look at the warning signs. And one of the major signs is when the nucleus stops rotating during the cataract surgery. It's a very important sign. Stop, think, and then go ahead. Suddenly a deepening of the AC, or if there is a decentration of a heminucleus much beyond what you would expect, vitreous strand, and obviously dropped lens fragment, then if you continue, it is disastrous. So don't ignore these signs. So this is one such situation in which the surgeon is making a trench, and then he has a doubt whether he's caused a PC rent. So he tries to separate, and then he sees a suspicious PC rent there. When he tries to rotate, see, rotating and the pieces just bouncing back. This is a very important step, indication that there could be a PC rent. And here again, the pupillary slap sign or the AC deepening. See, while he is going deep, suddenly now the pupil is snapped and the AC has become deep. Very important sign. Okay, this is the dislodged heminucleus. See, half the nucleus is removed. You can see it is tilting, slightly tilting. So it is the clear area is seen on the right side, and this is a major indication that you are in a soup. Okay, then obviously this is the nucleus drop. You know, he is trying to pull a peripheral, and this thing is already dropped. So again, instead of pulling out, you should put viscoelastic, plug, and then go ahead. So what do you do? At this point in time, there are two things. One is your cognitive skills and your surgical skills. Both have to be used. And do not panic. First of all, do not pull out the instrument, do an OVD exchange, take a minute, gather the information, okay, what exactly is going on, assess the situation, take a decision. If you are a God-fearing man, you can even pray for a minute and then take a decision, have a plan, and then go ahead. So if it's an early PC tear, the first thing is do not harm, do not cause more harm. That's why I said do not pull out. The moment you pull out, the PC tear is going to extend. You can even have an immediate drop of the nucleus or the nuclear fragments. So always, do not deflate the anterior chamber, put in viscoelastic, plug the PC rent and avoid vitreous coming up, stabilize the fragments. Whenever necessary, if you are not able to bring up the fragments into the anterior chamber, then use a dry vitrectomy, and if necessary, use triamcinolone. The larger fragments can be visco-expressed. You should also do a cleanup vitrectomy. Don't stop with just removing the fragments. Try and remove as much of the cortex as possible using a vitrectomy IA switch. You can decide whether to implant an IOL or not. If it is a full hard nucleus which is gone in, and if you think your vitreoretinal colleague may need to float it up with the PFCL and bring it through the main section and remove it, don't put an IOL. In all other cases where you think the VR surgeon can remove it with the fragmentome, place an IOL, do a thorough vitrectomy, let there be no vitreous, place an IOL, do a PI, and do a final check with a triamcinolone. And always respect once you're doing a vitrectomy, do not pull on and this can cause a traction on the vitreous base, and that can be disastrous. And you always use a low cut rate, low vacuum, and a high cut rate in these cases. So here, sometimes it can be a false alarm. Like in this case, there is a suspicious PC rent here, but then you see the surgeon tries to confirm it by rotating the nucleus. He just puts in viscoelastic and he rotates. And once it rotates freely, then you don't need to worry. See, it is freely rotating. You can go ahead with phacoemulsification. And here again, sorry. And this is a early fragment drop. Okay. So he tries a peripheral chop and it is going into the periphery and he doesn't realize, he keeps on rotating. It's not rotating. He keeps on attempting this one, and then you have a sudden fragment drop. And by the time it is evident, all the damage has been done. See, now he's again trying to rotate and the fragment is dropped. So in these cases, you have to go in, try and remove stabilize the pieces, remove it. You can put an IOL in the sulcus because the fragment may not be needed to remove. And then at the end of the case, he'll have equally good vision. Do a PA also. And yeah, in larger pieces, you can go ahead, extend the wound and then remove it. And here again, it's a nucleus drop into the periphery. And here, so at times, you may need to do a pass plane. Always stabilize, use triamcinolone if necessary. Yeah, and do a vitrectomy and continue. And here a PP vitrectomy is necessary because a large tongue has been remaining in the posterior this thing. And you can place an IOL in the sulcus and then use a fragmentome. And to avoid an undersized rhexis, try preventing a second instrument trauma and avoid peripheral or a phaco push in the periphery. And in late phaco, it is because of your settings, post-occlusion surge, aggressive phaco. You can see the peripheral tear very clearly because there's nothing else. Like in this case, you can see there is a rent which has happened. Again, similar picture. So in late cases, management, you should recognize the complication, always do an OVD exchange. If possible, control the tear into a PCC, use triamcinolone to confirm that all the vitreous has been removed, and then you can use your this. For example, in this case, you see a rent, and then instead of pulling out, you put in viscoelastic so that the tear doesn't exist, and then go ahead. So the OVD exchange is very important. And in this case, after implanting the IOL, just make sure that all the this thing is removed. You can be little more luxurious in using after putting the IOL because nothing much will go into the posterior chamber, the posterior segment now. Yeah. So to prevent, go for softer settings for the final, stay central and bevel up. Thank you very much for our patience.
Thank you, Dr. Soni, for that very informative talk. So because of the positive time, we'll take discussion at the end. So next talk is by Dr. Mohammad Shabazz. He'll talk on tackling the unwanted guest, the vitreous.
Good afternoon all. I'd like to thank Dr. Sandhya for giving this talk to me. And I think most of the part is covered by Dr. Soni itself. So I'll just show you the videos. I'll skip first 2-3 slides. So these are just the indication what precaution you have to take. So we'll directly go to the videos. Now it's in continuation with Dr. Soni. So this video is about like how to go about and do. So this it's very well it was going on like and as usual they are doing 4-quadrant technique and beautifully divided. This was done by my PG, and once we come to this stage, you see there is a rent in this. So at this stage I have to intervene then because vitrectomy we have to do. Now as you have to increase maximum cut rate should be there, whatever cut rate you have initially, because if your cut rate is low, it will drag the vitreous and it will cause inflammation in. So maximum cut rate, and once you are thorough, you have thorough with vitrectomy, you can come back to IA cut. In IA cut means the aspiration will be first, the cut will be second. So this will help you to aspirate the cortex. So now I am in IA cut, I can just aspirate the cortex, bring, and then I give a cut. So you can remove the cortex in this way. And then because this was a SICS, so we implanted the lens in the sulcus. And this closed again. Now coming to the second case, here she has done the red, pupil is small, and then she has called me. So, and the large tracheum is also there, so I removed the tracheum and I put a additional port. This is easily available in our OT nowadays, and it do helps in, because these cases you cannot afford to have viscot. So when you are using visco will cause intractable glaucoma, because if it goes backside, next stage or IP will be high and you cannot do anything. You have to do 3-port vitrectomy. So if you put this port, the fluid will not allow visco to go and sets in. So same thing I am showing in this also. Now vitrectomy I have done, and then I am removing cortex with the cutter itself. So initial vitrectomy has to be very thorough. You have to be, in this we are showing very less, but you have to be very thoroughly, and you have to be very sure about that you have remove all the vitreous from there. So to check, you can use triamcinolone at the, so if you put triamcinolone, all the vitreous strand will be visible to you. So now this again, this is a 3-piece lens. I will go to the next video. Now this is where she has done, completed, put the lens. Now 1 week I have seen the post-op. Now we can see here, this is pupil is updrawn. That means here the vitreous is incarcerated into the section. So now if this case remains, you will have multiple complications like vitreous big syndrome. You can have RD also. So you have to remove this vitreous and make the pupil round. So how to go about? Like first thing is that I have dilated the pupil because pupil was non-dilated, and then you use a spatula to bring the vitreous in the center. So see, the vitreous fibers are coming in, and then you do a thorough vitrectomy. So, and then you can go back under the lens, do a thorough vitrectomy, and after doing thorough vitrectomy, then you can revert back to IA mode, and then you can aspirate the cortex. So now I am using triamcinolone in this, so to check whether any vitreous strand is there in this section. And at the end, you can use pilocarpine. If you have a doubt, or if you feel, you can use a spatula, swap over the in iris plane. So this is like already present vitreous. So the first thing, because if vitreous is there in antechamber, you cannot do anything. So first thing you have to do is to remove the vitreous, because vitreous will not allow to do rhexis. It will not allow to do any other procedure. Every time vitreous will be coming in your probe. So you do a vitrectomy. And how good vitrectomy you do, there will be some part of vitreous strand in the section or in the side ports. So you have to be careful and remove that strand. See, this is what I am doing, and you can see that some strand will be there. You can bring it in the center. Now we can go about your cataract surgery, finish it off, the subluxated cataract. Another case is like this, like it's very difficult to recognize which side vitreous is. Anybody can guess? So the larger side is, this side is vitreous, because the zonal dialysis is in this side. So again, in this, I have used triamcinolone first, because I was also very much confused, because that line was making a demarcation line. So now we have to do again the vitrectomy. And here at the end, you can see there are some vitreous fibers which are incarcerated in your side ports. So it do happens most of the times. So you have to use a spatula, bring it in the center. You can do additional vitrectomy. Now this is another case in which the lens is dangling. Now it was a challenge for me, from my VR surgeon. Sir, I am there. If you can do, put the lens in the bag. I told, if I am taking the case, I will do that. So what are the challenge you will have? First is the vitreous, it is full of vitreous, lens is dangling. First thing is to bring the lens up. So for that, I have used a trocar with irrigation fluid. Now if you put that, the fluid will push the lens up. Now it has come into patellar fossa. Now you do the vitrectomy. So vitrectomy has to thorough up to like mid vitreous cavity. So again, as I told you, on the side ports it will come. Some vitreous fiber will definitely come in the side ports. So now I'm going behind the lens and I'm doing the vitrectomy. You can see these vitreous fibers are still there because of Tamslone it is stained, and I'm just removing that also because it will keep on coming. Now the very important question in this case is to do rexis. Rexis you cannot do normal, so this is like bimanual rexis I do. You make a nick, and then with nick you can make with the vitreous scissor, or and then you hold one end, and with the other microforceps you can hold other end. Now this is important thing which I want to show you in this. Now I am going, like I was very happy I have done, but at this stage you can see what has happened. So you have to be very careful when you're using a spatula, because all good thing is gone. Next is the patient. This is another case like it's a previously operated. Now if you do not take care of vitreous, this thing can happen, because vitreous will come and push the lens away, and the haptic is incarcerated in this. The first thing you have to remove the lens and bring it into antechamber. So this usually do not get, like, haptic will not get fibrous. So you can just dial the lens, and if it is not dialing, you can use your side port or any scissor to cut that fibrotic band. Now you cannot leave the lens in the sulcus like this, even after doing vitrectomy. So as we were discussing, we can enlarge the posterior fibrotic capsule and we can put the lens and do a optic capture, because if you leave it in the sulcus, it will again dip back. So these are the take-home messages. Vitreous in antechamber is not normal. You have to be careful and remove it. A thorough anterior vitrectomy is mandatory to keep vitreous below the iris plane. Do not get panic when you have a PC rent. It is a part of your surgery. Identify the rent and vitreous. 2-port vitrectomy is good. If you put additional port, it do help in reducing the visco going in the posterior segment. Use pyrocopine, triamcinolone and a spatula to make sure that vitreous has gone back to the below the iris plane, and close the section, preferably with suture. This is another case. If this just 30 seconds, like zonal dialysis, as she has already shown. So I think we can just put a CTR and close it. Thank you.
Thank you so much, Dr. Mohammed Shahbaz. Next, we'll have a very short and brief, sweet presentation by Dr. Jacob, and then we'll hand over the session to the next chief instructor.
Jake. Good afternoon to all of you. My topic is damage to the haptics while implanting the lens. Instead of going through all the slides, I'll just show you the videos. So here, depending on the kind of lens material, is a hydrophilic lens. The water content being high, you can see the trailing haptic gets caught in the pusher and it's broken there. Tedious surgery on a small pupil with hooks was done, and then you end up with a broken haptic. Here the lens is being divided partially. 3/4 of it is being cut with serrated strong bladed scissors, and slightly the wound is extended, and you can see a firm lens holding forceps is introduced through the tunnel, and the lens is rotated through with each half of the lens being carefully removed from the bag and outside without damaging the capsule. The next one is another technique. This is a hydrophobic acrylic lens. You can see the leading haptic is caught there inside the optic, probably because of poor loading of the lens, and at least half of the haptic is torn there. And this is video by Dr. Minu, actually borrowed it from him. showing a scaffolding with a new lens being introduced into the bag, and then the optic being cut into two halves totally, and each half being removed. These are different techniques of removing a damaged lens without extending the wound. This is being removed, each half is being removed. You can even remove the whole of the IOL by extending the wound to a larger size, and probably that might require a suture. Thank you.
Thank you, sir, for that short and informative presentation. With that, we are coming to the end of our session. I thank all my co-instructors for their excellent presentation and participation.